So, uh, first of all, hello to my colleagues and friends from all over the world. If you're listening to this webinar, of course, it's a great honor for me to share some information, to share some cases, and especially about aligner treatment, and especially about cases where we need bodily movement, root movement, like distalization or space closure, because I personally think that aligners are the future of orthodontic treatment. I don't think that we have many brackets in 20 or 30 years that we are bonding. So aligners are for sure the future. They're getting better and better. The clinching is getting better and better. But we do see problems if it comes to bodily movement, and I will speak about this. So again, I'm sitting in Düsseldorf. I'm there at the university, Department of Orthodontics, and this is where I'm right now. And again, hope to see you soon personally at a congress after the Corona crisis. Düsseldorf is a beautiful city, and again, if we are able to travel again, you are very welcome to visit us here at the university. It's a lovely city. It's just 10 minutes to get from the airport to the city center. So very easy, not so much traffic. So please visit us after the Corona crisis. Uh, as mentioned, I think aligners are the future. We have a couple of advantages. It's more aesthetic, but additionally, we see a low risk of developing caries, which is a big advantage, especially for our younger patients. So two big advantages. And last but not least, the third big advantage, it makes fun from my point of view. How about efficacy? If we have a look at the literature, we can distalize maybe 1.5 millimeters. Um, that's another study where some heavy users of aligners distalized even more than 2 millimeters. I don't know how much this is a bodily distalization, but at least the crown was moved up to 1 or 2 millimeters. Uh, there are some heavy aligner users, they think I can do everything with aligners. The question is this really the truth? And we have to discuss how many aligners and refinements are needed if you want to do bodily movement. The molars are tipping. You take another impression or do another scan, it takes so many years. So most of my patients, they are motivated for 1 year, maybe a little bit more, but after 1 year, they want to get finished. So how much time is needed? How much elastics are needed? If you want to distalize with the sequential distalization procedure, it takes so much time and you need so much compliance in terms of elastics. Yeah? And predictable bodily movement, this is a problem. How about class 2 elastics, especially if you have asymmetric situations? You may get an asymmetry in the lower arch if you use class 2 elastics. And last but not least, if you use T's for anchorage, you may see root resorption as well. This is an open bite case from our study group, and the doctor wanted to intrude molars up and down elastics were applied. And please have a look at the roots of the central incisors. This is before and after up and down elastics. It looked like this. So severe root resorption. So maybe from time to time it's better to use not teeth as anchors, but maybe mini screws. They may fail in the palate, the failure rate is very low, but you never see a mini implant resorption or something like this. So, what are the major problems if it comes to aligner treatment? Bodily movement, as mentioned. Yeah, in the transverse dimension, it's impossible to expand bodily. The teeth are going to move. Um, and next to expansion, you see two papers. It is distalization and space closure. Space closure may be more than 1.5 or 2 millimeters. You can close small spaces. This is not an issue. But if you want to close spaces of maybe 5, 6, 7, 8 millimeters, this is impossible with aligners only because you see tipping in 9 out of 10 cases. Maybe in 1 out of 10 cases it works. Yeah, you see lectures from heavy aligner users where they are closing spaces. It works in some cases, but how predictable is this? This is a question. I'd like to show you two cases treated from another orthodontist by another orthodontist. First case, adult patient with a severe protrusion of the incisors in the upper arch. The doctor wanted to take out the first bicuspid in the first quadrant and the first molar in the second bicuspid. And then it was time for space closure, and you see what happened. Severe tipping of the teeth, and this is what we usually see. He wanted to correct this afterwards with brackets, because if you try this with aligners, you will see in many cases severe tipping. Another case, a second case, treated in private orthodontic office, class 2 div 2, some crowding in the upper arch. A doctor wanted to take out two bicuspids and wanted to do space closure to get some space to correct the upper incisor crowding. And please have a look what happened. Severe tipping of the molars, and this is what usually happens. And this is why I'm lecturing today. I like to show you how we can avoid this tipping if it comes to distalization, mesialization. In the next webinar, I will speak about expansion as well. The doctor wanted to correct this. He bonded some brackets to upright the molar afterwards. Yeah? But again, using just aligners, this will happen quite frequently, even if you use attachment. So let's summarize. What are the difficult treatment tasks I like to speak about today? Bodily movement, if you want to distalize bodily more than 2 millimeters. If you want to do space closure, maybe more than 2 millimeters. We do see severe problems if we are using aligners only. And again, the question is, can TADs help us, and how can they help us? Do they help us if you put them in the infrazygomatic crest? No, because the teeth are still going to tip. We need a guidance that the teeth are not going to tip, so we need some kind of a sliding mechanics in the palate. So where to insert them? Not in the infrazygomatic crest, not interradicular. Why? If you put them in between the teeth, you cannot move them anymore. Secondly, of course, the failure rate is much higher if you put them interradicular, buccally. Okay, so is the tuberosity a good idea? From my point of view, no way. It may you may be successful in some cases, but in many cases, the mini implants are going to tip like this mini implant tipped forward. Yeah. Why? Soft tissue is very thick. bone density is very low. So many TADs in the tuberosity will tip like a hot knife in butter because of the low resistance, soft tissue thickness, and low density in of the bone in this area. So not a good insertion site, not very predictable from my point of view. We have inserted so far around about 4,500 mini implants. So we have seen many failures as well, and I'd like to speak about failures today as well. A nice paper published by Jan Hofer. He compared mini implant success rate in the palate versus mini implant success rate of buccally inserted mini implants. And there's a big difference. And of course, we want to be successful. We don't want the stress with our patients. Yeah, if you have a failure. So, from my point of view, and not just from my point of view, the users of palatal implants, mini implants, is getting more and more every month. So this is by far the best area for mini implants. Okay, forget the infrazygomatic crest. It's stressful. You are in movable mucosa, and you don't see a bodily movement of the teeth. Maybe some tipping. Forget the tuberosity. Forget the buccal mini implants. In the upper arch, from my point of view, by far the best area is the anterior palate. We started to use this area a long time ago. This was one of our first papers, 2008, and we have shown a couple of appliances. This is the first MAPA appliance that was ever published in 2008. Now there are many followers like Von Moon, etc. Yeah, so but we started a long time ago with this. We call this hybrid Hyrex because it's a mix of mini implants and teeth as anchors. So how to insert? I think it's quite easy. Insertion in the palate is, from my point of view, much easier compared to buccal mini screws. Why? You don't have to care about roots at all. And again, success rate is very high. Maybe at the beginning, your failure rate is a little bit higher because there's a learning curve. We have to additionally have a look on the hygiene. If the patients don't clean, we do see still some failures. So very important, patients have to clean the mini implants in the palate. They should use chlorhexidine jelly for the first week to avoid inflammations. Where to insert mini implants in the palate? It's very easy. This is one of my favorite slides. We call this T-zone. T-zone is very easy to identify. Stay distally from the rugae. And please do not insert mini implants here like some doctors doing this for MAPI. Yeah, the bone is paper thin if you want to have a look at the cone beam CT. So either stay in the area of the bicuspid paramedian, or if you want to insert median, you can insert bicuspid or molar area. Okay, so take home message, stay in the T zone. You don't need a cone beam CT to find this T zone. Primarily have a look at the palatal rugae and stay distally. Another paper where we have checked the best insertion site. We additionally have checked the angulation. To make a long story short, it's again this T-zone. And don't insert posterior laterally. Don't insert here. There is no bone. Okay? If you want to insert in the molar area stay very close to the suture. So is it better to insert median or paramedian in this T-zone? And we did a couple of research studies on this topic. And we found out in the last years that paramedian insertion is better. So since maybe 3-4 years, we are only inserting paramedian. Today, you will see a couple of cases with median mini implants. Yeah? But we saw over the last 15 years some failures of median mini implants, especially in young children, because the suture area is not dense enough. And in adults, it's vice versa, interestingly. Median, the bone density is too high. So sometimes we are not able to insert mini implants median because there's a lot of cortical bone. Again, to make a long story short, in young kids, in adolescents, in adults, we are nowadays only using the paramedian insertion site. This is what we learned in Düsseldorf. So if you want to start next week or tomorrow, I'd like to give you some tips. You may use topical anesthesia before you do a local anesthesia. We are doing 2 shots, one left and one right. We are using this cytoject syringe because it's very easy. The needle is very tiny, so it makes it a very insertion is very comfortable using this syringe. Do we need pre-diddling? Only in adults, okay, especially medium. So sometimes the bone is so dense we that we need some pre-drilling. But you can do this manually without cooling, because if you do this manually, the speed is very low, so it's not a big issue. So these are the dimensions we are using, primarily 2x9. We used to insert one one anterior, one posterior, then the posterior one was 2x7. Now we switched to paramedian insertion, and mostly we are using 2x9 millimeters. Yeah? I love this insertion driver, electric insertion driver by NSK. And if you want to use mini screws in the pallet on a regular basis, I strongly recommend to buy this driver because it's fun. You just push a button, count from 10 to 0, and then it's done. Don't stop the insertion, even if the patient feels some pressure. Don't stop, continue, count from 10 to 0. This is my clinical tip. Then the patient does know it's done in a couple of seconds. So, how to connect your palatal pads with the appliance? It's recommendable to use mini implants with abutments, and this is a big trend worldwide. Yeah, years ago we started with a benefit system, and now there are many copies, followers using mini implants with abutments because we need a good coupling from the mini screw to our wires. We used to do this with resin and with steel ligature, but this is stressful and not so stable. So my recommendation, use an abutment system and then wires in place. This makes it quite easy. After insertion of the mini screws, you can adapt these plates, the super construction, if you are good, directly chair side. Usually we did an impression and adapted this on the plaster model, and in recent technologies we are using CAD-CAM techniques, so we don't have to bend anymore. We are CAD/CAM designing and laser printing our appliances. But this is the conventional approach. Insert the screws, take an impression with these impression caps and the silicon impression material. So the idea is to transfer the intraoral situation on the plaster model. Again, nowadays we are using scanners and all this fancy stuff, printed models, and but if you don't have this technology background and you want to start with the conventional approach, this is how it goes. Again, many cases are with median screws. Nowadays, we are using primarily par median screws in this kind of plate, or two rings, Hyrex rings, and we are connecting this with a wire. Okay, it's always the goal to make this, to clean this for the patient, to clean this easily. So today, I like to speak about the combination with aligners because I think this is a super smart combination. Yeah, super, super smart. Yeah, I love it. We have hundreds of cases about this combination. Today, I just have 1.5 hours or a little bit more, so I cannot show you all the cases, but I like to give you some tips and I like to show you some problems as well. So we started with a two-phase protocol. What does this mean? Two-phase protocol means we first had the TED appliance for distalization, mesialization, maybe expansion. I will speak about expansion in my next webinar about aligners. Today, I will keep the focus on distalization and mesialization. As soon as this goal is achieved, we take an impression or do a scan and finish the easier case with aligners. So the goal is the strategy, do the difficult things like bodily movements of teeth, space closure, for instance, with the sliders, modify or transform the case, a difficult case, into a much easier case, and then finish the easy case with aligners. This is how we started with this two-phase protocol. Yeah? So first, the difficult case, not enough space for the front teeth, distalized with a slider, in this case a Bennett slider, due to interdental fibers, bicuspids and canines are following, not 100%, but maybe 60-70%. And now, after distalization, this is an easy case for finishing with aligners. So this is the idea behind it. Yeah? Combine it, and again, we started with a two-phase protocol. Nowadays, we have many cases where we are distalizing the molars and simultaneously using aligners for alignment of front teeth. It's faster, this one-phase protocol, but we have to synchronize the slider with the aligners. I will speak about this later. Why or what do we have to think about if we want to synchronize slider and aligners? If you want to distalize the molars, they will not rotate, they will not tip. So very important to check this in your ClinCheck, for instance. So again, we started with a two-phase treatment 15 years ago. Nowadays, we have many cases where we do aligners and sliders simultaneously. Yeah? Like everything in life, both has pros and cons. Yeah? And the one-phase treatment is maybe a little bit has more, yes, it's a little bit more speedy, but you have to again think about the synchronization of aligners and the sliders. So this is what I will, these are the topics I will speak about today: distalization and mesialization. And my next webinar, I will speak about rapid maxillary expansion, alignment of impacted teeth, molar intrusion, front in extrusion, etc., etc. So more specials. Today, more the sagittal treatment goals. So if it comes to distalization, how can we design the appliance? And maybe 20 years ago, we started with indirect anchorage. What does indirect anchorage mean? Indirect anchorage means we are coupling our bicuspids with one or two pedal tabs. Why? If we have open springs, we don't want the bicuspids to move forward. After distalization, we have to change the appliance into a molar anchorage transpalatal arch. So it's a little bit a strategy with two different appliances and two different faces. I don't like that too much, to be honest. I like more the strategy on the right side. It's a direct anchorage strategy. That means we are applying the force directly to the teeth we want to move. And mostly we want to distalize the molars. So what are the advantages? It's faster. Why is it faster? Because bicuspids and canines are following due to interdental fibers. We just need one appliance. We don't have to reconstruct the appliance and insert a second appliance. We are using the same Bene slider that we have used before for distalization, after distalization for molar anchorage. We are just removing the springs, or we are using steel ligatures. Big advantage, and this is why we are sitting here, no brackets are needed. On the left side, we need brackets in place. So we can finish the case easily with aligners. So this is an adolescent, 16 years old, asking for non-extraction treatment, and we need a lot of bodily distalization. This is not a case for class 2 elastics and sequential distalization, because you can distalize 1.5, maximum 2 millimeters. Here you need 5-6 millimeters of distalization. Additionally, please have a look at the inclination of the lower incisors. It's not recommendable at all to get some more lower incisor proclination. So very important. Maybe it's better to apply just the force in the upper arch. Median screws, today again I would insert them paramedian, but it's always the same area, this T-zone. So please have a look at the Ruge. 1, 2, 3 Ruge. 1, 2, 3. So we are in this T-zone. This is how the T-zone looks like. It's very easy to identify this T-zone. Not a big issue. This is a slider in place. And this is a couple of months later. What do we see? We are distalizing the molars, and bicuspids and even the canines are following. Because the teeth are friends. They like to stay together. They are not following 100%. They're following maybe 50-60%. So what else do we see? After distalization, we are removing the springs to modify our device from an active distalization device into a passive molar anchorage device. This takes 30 seconds. Very easy. But we don't have to reconstruct our appliance. So now this is an easy case to finish with aligners. Yeah? Typical two-phase treatment. First phase, molar distalization. Then in the second phase, take an impression or a scan for aligners, but leave the slider in place for molar anchorage. Yeah? Because we don't want the molars to mesialize again. This is the case at the end of the treatment. Yeah? No herbs, no class 2 elastics. Yeah? Just bodily upper molar distalization. Yeah? This is the first paper we have published about the combination of banner slider and aligners. And again, these are friends, they like to stick together. Yeah? So please check the situation before and after distalization. How about speed? Average speed of distalization is 0.6 millimeters per month. We have to know this speed because if you do aligners and banner sliders simultaneously, you have to synchronize the amount of distalization with your clinching. Yeah? So again, 0.6 millimeters each month. So after distalization, took around about 8 months, scan for aligners and finishing with aligners. Sometimes we leave the screws in place just for fun. Yeah? For the patients, for the young patients, it's like a piercing. Yeah. So I offer them, should we remove it now or in a couple of months? And most of the patients say, no, leave them. I show them to my friends in school. So you can leave them for a couple of months. This is after removal of the screws. We do removal of the pads usually without anesthesia. And a nice bodily movement. This is a big difference to distalization with aligners only, where you see more or less just tipping of the molars. Yeah. So let's speak about the problems. I like to give you some tips how to combine aligners and the slider. We had 12 years ago, 13 years ago, we used these bands, but aligner companies had some issues. So nowadays we are using these bonded tubes. Why? It's much easier that the aligner and this slider can be used simultaneously. So how can the interference be designed? Design idea number one, you can order button cutouts from all the aligner companies. Usually the button cutouts are used for attachments for class 2 elastics, whatever. You can order them palletly as well. Or, this is my favorite, you insert the slider, then take a scan for aligners, and the aligner is covering this area. So it's a little bit like a big palatal attachment. Okay, and this is how we design this connecting area with an undercut. Yeah, so that the aligner has a super proper fit on top of the dentition. You see, first, you see after distalization, we insert a steel ligature. Now the active banner slider is modified into a passive molar anchorage device. This is how we couple our mesial slider and banner slider for distalization. We design a nice undercut. You see this right here. So it's like an attachment. Okay. So let's have a look at a couple of patients using these bonded tubes. A young class 2 patient, we need maybe around about 3 to 4 millimeters of distalization. We have a protrusion of the lower incisors, so don't use class 2 elastics. My recommendation. Bend slider in place. In many situations, I'm using some um, resin bubbles to make the appliance a little bit more comfortable. This is immediately after insertion. This is 7 months later. And now you see a nice bodily movement and many small spaces. The bicuspids and even canines are following. Yeah? Now the molars are class 1, and then you can take a scan to finish the case with aligners. So this is more or less what it's all about. And you don't need aligners for 2 or 3 years. You need aligners for 3 to 6 months, not more in most of the cases. Yeah? This is the patient at the end of the treatment. A nice class 1 occlusion without class 2 elastomy. Another patient, adult patient with a asymmetry. We needed, especially in the second quadrant, a lot of distalization to correct the class 2, to correct the crowding. Maybe 5 millimeters of distalization in the second quadrant. So a lot, to be honest. And don't use asymmetric class 2 elastics. You may push your lower teeth into the wrong position. Very important. Maybe the lower teeth are in the perfect position, but if you use unilateral class 2 elastics, you get a shift. So if the problem is only in the upper arch, use only in the upper arch additional anchorage. So we distalize. You see bonded tubes on the 7. Mostly I bond to the 6, but if wisdom teeth are in place, I'm bonding to 7. Yeah? See many small spaces. Additionally, I've bonded to the bicuspid because on the second quadrant we needed so much distalization. After distalization, scan for aligners and finish the case as you can see right here. This is second. This is after the aligner finishing. As soon as the spaces are closed distally, you don't need the slider anymore. We only need the slider in place as molar anchorage. And again, if the spaces are closed distally, you can remove the aligner as a slider, as you can see right here, and do the aligner finishing. Maybe you have to do spend some more aligners, have to do refinement. So before and after. Nice bodily movement. This was published last year in the new textbook from Ravinanda about temporary anchorage devices. It was a severe asymmetry after removal of the mini screws, before and after. Another case where we have a severe asymmetry. This patient underwent an orthodontic treatment when she was a child, and an orthodontist took out 4 bicuspids. Please have a look at the severe midline deviation in the upper arch. What can we do now? We cannot take out another bicuspid in the second quadrant. In this case, we really need skeletal anchorage. And don't insert in the infrazygomatic crest, because you will see just tipping of the molars. But we need a bodily distalization of maybe 3 to 4 millimeters. Uh, so mini screws in place, slider in place, unilaterally activated. You see, we are pushing the second molar distally. Molars and bicuspids are following by themselves. In this situation, also because we have aligners in place. Yeah, you see a nice bodily movement of the molars. You don't see this bodily movement using class 2 elastics. Yeah? So after distalization of the second molar, a refinement, and at the end you can make a derotation. Very important. Yeah. If the slider is removed, then you can derotate to 7. Very important. First, retraction, bodily retraction. This works if you have distalized. Following is much easier, so the risk of tipping is much lower. Yeah? So this is how we modify our active slider into a passive molar anchorage device. Use a steel ligature. This is now in the finishing phase. At the end of the treatment, this it's going to be published in the JCO in the next couple of months. At the end of the treatment, midline is now perfect. We have a class 2, a class 1 now, also in the second quadrant. This is a case where you really need skeletal anchorage. You see before and after superimposition of the maxillary meshes. Another case, and this was one of our first cases where we did Bene slider and aligners simultaneously. So we are distalizing the molars, and at the same time we are aligning the front teeth. One phase treatment, simultaneous distalization. How can we do this? Mostly I'm inserting the Bene slider, then do a scan, and the aligner is covering this connection area. In this case, I did something else. I ordered button cutouts. You see them here. Yeah, I don't like this too much. Nowadays, I would bond on the first molars, not on the second molars. Why? If you bond on the second molars, you have a little bit the risk that you're distalizing the molars, but your aligner cannot retract all the rest of the teeth. So my recommendation, bond on the first molars and order the aligners after scanning of the Bene slider. And don't use these button cutouts, but use the situation that the aligner is covering this coupling area. Okay, so you have a nice bodily distalization, and simultaneously we are aligning the front teeth. And this one phase treatment is faster because at the same time, again, we are using the aligners. At the same time, we are doing the distalization. This is it. The end of the treatment time, 8 months. We didn't need so much distalization, maybe 2.5 or 3 millimeters. Another patient where we did simultaneously aligners and the Bene slider. We need, especially in the first quadrant, some distalization. We needed also intrusion of the molar, so you can change the angulation, that the molars are not just distalized, but simultaneously intruded. Okay. Sometimes we are adding this intrusive force component using a 3-finger plier. Yeah, so you can always don't remove the slider. Do this intraorally. Expansion, compression, extrusion, intrusion. Yeah. But again, in this situation, the slider is passive. You see this spring is not activated yet because we do a scan for the aligners. As soon as the aligners are there, then we are activating the slider. Very important, if you do this simultaneously, we have to synchronize the slider and the aligners. Okay, so don't do any rotations of molars at the beginning. Just do a bodily distalization in the clinchic. Very important. Yeah? So you can distalize all teeth simultaneously if you want to. Nowadays, I would recommend to do small spaces because then the aligner is covering the teeth a little bit better. But you can do full arch distalization. You see here the distalization goes on, and this is after distalization. You see now a nice class 1 occlusion. And again, for the last finishing steps, you can remove the slider because you don't need it anymore. As soon as the teeth are retracted, the slider is not needed anymore. This is the patient at the end of the treatment. So again, I love this combination of sliders and aligners. I'd like to show you now one case and one maybe technical trick. If you have, for instance, a tooth that is tipped palatally, we can add uh, small gadgets to small springs that we don't need at the end many aligners. The less aligners we need, maybe the better. Maybe you're doing in-house aligners. If you're doing in-house aligners, you would really appreciate that you maybe need just 2 or 3 aligners and not 20. Okay, so my recommendation, add some gadgets like this small spring. In this patient, we wanted to distalize the molars, yeah, and push the lateral incisor a little bit buccally. The treatment goal was to get some space for the front teeth and to need as less aligners as possible. And it worked out fine. You see now many small spaces, and now it is a very easy case for aligners. Okay, so add these small springs. The more you can do with this appliance, the less aligners you need afterwards. Again, this is important if you do the aligners by yourself. This is a patient at the end, a nice class 1 occlusion without any class 2 elastics. Patient at the end of the treatment. Another patient, adult patient, where we need unilateral distalization, maybe 3 millimeters. Slider in place. Take an impression for aligners. Nowadays we have a scanner. I would do a scan. But if you want to do an impression, I recommend to use some wax. Otherwise, you cannot remove the silicon impression easily. Okay. Continue now distalization. This is how it looks like. The aligner is covering this connection area. It's like a big attachment. Yeah? You see a nice bodily distalization. And we are now distalizing the molars and simultaneously aligning the front teeth. It's always the same. As soon as the molars are in the desired position, use a steel ligature. Then your device is modified from an active sliding distalizing device into a passive molar anchorage device. Okay, this is the patient at the end. A nice bodily distalization. Usually I recommend to remove the wisdom teeth, but in this case we had lower wisdom teeth and the patient asked, can we not just check if they maybe can stay? So some more tips, some more problems that may occur. If you are treating many of your patients with aligners, you know that deep bite correction is not so easy. It is more difficult to correct a deep bite with aligners compared to fixed braces. So in this case, we had a patient with a deep bite and need for molar distalization. You know the story. Insert the Bennett slider. This is after 8 months of treatment. After distalization, insert these T ligatures. Now the molars are fixed. Take an impression or do a scan now for aligner finishing and retraction of the bicuspids, canines, and front teeth. This is how it looks like. But I can tell you why am I showing you this case. It was much easier to distalize the molars, retract the front teeth, compared to get out of the deep bite. So the problem was not distalization, the problem was get out of the deep bite. This is what I learned in the last 10 years using aligners. You need good attachments on the bicuspids, on the lower bicuspids. Yeah, big attachments that you get intrusive component on the front teeth. Yeah, so always have a look on front intrusion correction of the deep bite. Very important. Another patient where we had some problems. And again, I think it's very important to speak about the problems as well. Young patient, and I was super enthusiastic in this case because I thought I'm super smart. I can distalize molars and the canine. This patient had a missing lateral incisor in the second quadrant. Usually, I personally prefer to close the space, but parents and patient opted for space opening. So again, I thought I'm super smart. I can distalize the molars and simultaneously, maybe you see these elastic chains. I thought I can again retract the canine. I attached an elastic chain lingually and buccally, so the load on the mini implants was too high. And again, there were median inserted, so this was one of our cases where we had mini screw failure. This luckily happens very rarely, but it happens from time to time, and then you have to know what to do. And what is the solution? Because we made a promise to the patient that we can distalize here with our slider. So it's not a good idea to say, it didn't work, we try something else. My recommendation, if you have a mini implant failure, which happens luckily quite rarely, this is a emergency appliance. We call this tripod. Okay, tripod because it is fixed on 3 mini implants, 2 power median and 1 posterior median. Yeah, and there's also a Bennett plate available for this, so you don't have to do any soldering or welding. Yeah, so this is our emergency appliance tripod, and we have tested around about maybe 10 to 15 tripods. None of them failed. They are super stable. You see, the canine was now successfully retracted. Yeah, and because tripod is super stable. Yeah, so we distalized, You see many small spaces, distalized the molars, plus additionally retracted the canine. This is after removal of the slider. You can leave the slider for molar anchorage purposes. In this situation, we have modified it into a passive TPA, which is also possible, less parts. So usually I am using the Bennett slider for molar anchorage, but in this case we have made the appliance a little bit more comfortable for the patient. Yeah, so this is a TPA, but we need something that holds our molars in place. Yeah? Now, second phase, retraction with aligners, space closure of the small spaces posterior, and you see a nice bodily distalization. And this is again always our primary goal. And a nice gadget, we use the tripod mini implants at the end for this temporary ponting. So don't unscrew your mini implants. Use them for a second or even a third purpose. It looks like this for a couple of months, and at the end of the treatment he was ready for a dental implant, or in the meantime he had this bonded bridge. Another patient where we need a lot of bodily distalization. Another patient where we did a one-phase treatment. What means one-phase treatment? Insert the Bennett slider passively, don't activate it. Take a scan for aligners, and as soon as the aligners are delivered, distalize the molars and simultaneously correct the anterior crowding. So this is the Bennett slider in place. I used in this case a tripod from the first beginning, because I think in the week before I had a failure with two median mini implants, so I said I don't want failures anymore. So if you want to, you can start with this tripod from the very beginning. So insert the Bennett slider passively, do a scan for aligners. As soon as the aligners are delivered, we are activating the Bennett slider. Very important, in ClinCheck here you see the attachments. So the aligner is covering this area. Very important, just bodily movement. Don't do any rotations, tippings of the molars. Why? It's not possible because they are connected to the slider. You can do this at the end of the aligner treatment, but not during distalization. So again, simultaneously distalization plus alignment of front teeth. One phase treatment, and is the most speedy treatment that we can offer to our patient. This is a turbo for aligner treatment. So treatment time 10 months. We distalized round about 6 millimeters in the first quadrant. This is never ever possible, of course, with class 2 elastics. In the second quadrant, we had round about 2 millimeters of distalization because we had a midline deviation. So this is super speedy. Slider distalization in combination simultaneously with aligners. So, second topic for today is space closure, mesialization. And from my point of view, very interesting topic, because if you don't use this slider, you will see a lot of tipping teeth. I can promise this to you. This was the first paper about the mesial slider. And the appliance is very easy if we have missing first molars or second bicuspid. We are using these headgear tubes. Why? Because they are very rigid. You don't see tipping of the molars because in these situations we don't want tipping of the molars. So this is before and after, took around about 12 months. And many doctors are asking me, do you have a look at the recessus of the sinus? And usually I have a look at them, but I never saw a molar that we cannot move. Yeah? So even if the sinus has a deep recessus, I promise you, you can move the teeth through the sinus. It's just bone, it's not metal. Okay, so you can close all spaces. I promise it to you. If you have a recessus, a deep recessus, maybe the risk of tipping is higher. So this is why we are using this headgear tube. This is soldered to the bands. You have to keep an eye on the situation to avoid tipping. Yeah. But you see a very nice bodily space closure without brackets. Yeah. You don't need brackets. And 8 wisdom teeth are following in most of the cases almost 100%. Yeah? If you have some small spaces at the end, you can spend some alignment. This was published 2019 in the AJO. It was also on the cover. So if you want to see how to work with this mesial slider, I recommend to read this paper. In many cases, we have missing second bicuspids. In this young lady, we had missing of all 4 bicuspids. Yeah? And I like to show you how to close the space without brackets, without any compliance, just by using this mesial slider. Okay? And the patients, they love it because they don't have to do anything. Spaces are closed with invisible. Yeah. So now it is an easy case for aligners. Here it is a very difficult, almost impossible case for aligners. So I like this combination of sliders and aligners. This is after finishing. Yeah. In the lower arch, we don't have a pallet. We cannot insert sliders. So in the lower arch, brackets were bonded. Yeah. And we are not using screws, buckle screws, because of the high failure rate. We are using this mental plate. We are primarily using this mental plate for class 3 traction in growing patients like Hugo de Klerk. But we are also using this mental plate for space closure, and it is super reliable. Yeah? Failure rate is 0 before and after. Another patient missing first molars, asking for space closure. And I think it does make a lot of sense if the wisdom teeth are in place. Yeah? It is stupid to insert dental implants and remove the wisdom teeth. You would not do this with your daughter. Yeah? So have a look at the sinus. Is this a problem? Well, this seems not to be a problem. Even if the sinus would be like here, you can for sure move the molars through the sinus. So these are the newest designs. I will speak about this in my next webinar. Nowadays, we are using CAD/CAM techniques. These sliders are printed. We are using insertion guides. Okay. Advantage, we can insert both in just one appointment. So the appliance is prefabricated. If you're interested, we have started a university spin-off company. It's called TEDman. TEDman, like temporary anchorage device, tedman.de. I will show you how to check out this service at the end of my lecture. So these are printed appliances. Yeah? You can insert appliance and the slider in just one appointment. So in this situation, simultaneously aligners. The alternative would be first close the space and then do aligners, but we have those patients asking, please, here my front teeth are not super. Can you do this simultaneously? Okay, so simultaneously space closure plus alignment. And I think this is a super smart combination. Yeah? Nice bodily mesialization. Just check out the situation of the second molars. Yeah? Bodily, it's not possible to do this with just aligners. Your molars will tip for sure. And now we can wait for the third molars. This is the patient at the end of the treatment. So if the spaces are more anterior, we are using bonded tubes in the area of the canines or first bicuspids. This is one of my favorite appliances or favorite designs of the mesial slider. I'm applying the force to the first bicuspids. I have a push, open push mechanics, and I have just a small force to the molar. So the primary force is applied to canines, or in this case, first bicuspids, using this open spring. Because the other teeth are more or less following. So this force is not so high. This is just a small, low force elastic chain. So we are doing a lot with this bonded tube. An adult patient, very difficult patient, asking for aligners and asking for space closure. And I wanted to upright this molar. And nobody worldwide can upright this molar with aligners. This is impossible, I can promise you. So, treatment goal, space closure, molar uprighting, and patient asked for aligners. Yeah. So what do we recommend? Combination of slider and aligners. In this case, a mesial slider in the second quadrant. Here, a mesial slider and a flexi tube. Flexi tube is a tube that you can activate for uprighting and derotation. Additionally, I spent a bracket on the bicuspid. So uprighting force buccally, uprighting force lingually from the flexi tube. Yeah? This is of course the best if you apply a force buccally and lingually. In the second quadrant, space closure with the mesial slider, you know the story. Spaces are closed, molars are uprighted. This is 15 months after start, and you see molar is nicely uprighted using this flexi tube. The space is closed in the second quadrant. And now it's an easy case for finishing with aligners. So we are removing the mesial slider, take a scan for aligner, and until the aligners are delivered, we are using a vacuum formed stent. Why? We are using this vacuum formed stent that the teeth are not going to move, because if you just say, patient, go home, see you in 4 weeks, the teeth may move and then the first aligner may not fit. So my recommendation, use a vacuum formed stent in the meantime until the aligners are delivered. 4 weeks later, Invisalign aligners are delivered. And now it's an easy case and was finished with aligners. The only thing, this is not finished yet, is a little bit uprighting of the molar, which is very difficult with aligners, I can tell you. So I'm still thinking about put some maybe 3 or 4 brackets to correct this molar. Another patient, similar patient, asking for aligners and space closure and space closure. Wisdom teeth is in place. So in this case, we have a mesial distal slider. That means mesialization in the first quadrant, plus, because we have a class 2 occlusion in the second quadrant, distalization here. Mesial distal slider. So we want to close the space here and distalize on the other side. So mesialized in the first quadrant, and if the bicuspid is in a good position, we are anchoring it. If the molar here is in a good position, distalization was 2 millimeters, we are anchoring it with a steel ligature. And the rest is now done using Invisalign. So this is before and after on the left side, before and after on the right side. So you can move the molars after you have distalized, after you have mesialized. You can move the teeth bodily with aligners, but not more than 2 millimeters. So the rest is done now with aligners. As soon as the spaces are closed, you can remove the slider and the patient is happy, because of course they're happy if you have removed the slider. Okay, so if the spaces are closed, remove the slider, do the last finishing treatment goals just with the aligners. This is a patient at the end of the treatment. Another patient, another young patient with missing upper lateral incisors. After removal of the baby canines, after 10 months of space closure. And I can tell you the patients love it. Bodily space closure, they don't have to do anything, it's not visible. And as soon as the spaces are closed, then we take a scan for aligners. So it's always the same. Do the difficult things with the sliders, and afterwards the easy things with aligners. So you can even do class 2 elastics. So very smart, very interesting. We are using the screws in the palate first to mesialize all teeth in the upper arch, and we're using class 2 elastics also to protract the teeth in the lower arch. So the screws in the palate can help us for both arches. This will be published in the January issue of the JCO. So have a closer look at this paper. After space closure, finishing with aligners. Always the same. Do the difficult things with the sliders. Afterwards, the easy things with the aligners. I think it's a super nice combination. So I personally like space closure if you have missing lateral incisors, and from time to time I do the composite reshaping by myself because I think it's fun. So this is how it looks like in this patient. I think it's a super nice result. I learned this from Björn Zachrisson, Marco Rosa, and also Björn Ludwig is one of the super experts if it comes to finishing after space closure. Another interesting patient. This patient was treated when she was a child. She has missing lateral incisors, and because it is not recommendable to insert dental implants in the aesthetic zone, the orthodontist in private office has mesialized 3 and 4, left a space distally of 4. Why? To insert dental implants when she is an adult. Now she went to the orthodontist and the implantologist because she was an adult and ready to go for dental implants. But have a closer look at the radiograph. There was not enough space for the dental implants. So I think this is another reason why space closure is in many patients much better, because we don't have this stressful situation if the patient comes to the implantologist when they are ready for dental implants and our roots moved into the dental implant sites. It's always a super stressful situation because then the implantologist says there's not enough space, you need another orthodontic treatment. The parents are going to the orthodontist, and the orthodontist says, yes, we can do another orthodontic treatment, but I have to charge you 5, 6, 7,000 euros or dollars. So it's always a stressful situation. So maybe this is another reason to go for space closure from the very beginning. It's an investment. It takes a little bit more time, but you avoid this stress. You avoid dental implants in the aesthetic zone. So my recommendation, if you have missing central incisors, if you have missing lateral incisors, if you have missing canines, think about space closure in young patients. And nowadays we have the mesial slider. We can do this unilaterally, bilaterally, especially if wisdom teeth are in place. So this is the mesial slider. In this case, I have added elastic chains to small hooks in at the front area of the mesial slider, but it's always the same. You see, after 10 months, spaces are closed. No compliance needed. Bodily space closure. Yeah. So I think it is a smart combination. At the end, small things with aligners. Always the same. Do the difficult bodily movements with the slider. Easy things afterwards with just some aligners. Maybe you can go for I7 Invisalign or Invisalign Lite. So you don't need so much aligners. It's not so expensive. So we went for space closure. Now we can wait for the wisdom teeth. In the first quadrant, the wisdom tooth has even erupted. Another case, a patient with missing second bicuspid in the second molar. She's an adult patient. And dental implant failed 2 times. Yeah, and the patient was super upset. And she said, I don't want any dental implant try anymore. I had so much pain. I paid so much money. She said to me, I heard that you are doing space closure. I want to go for space closure. And of course, she don't want brackets. She wants aligners for the minor corrections. So I recommended mesial slider. You see space closure after 10 months, but the molars, they have rotated a little bit. But this derotation is very easy for a liner. So again, always the same. Do the difficult things with the slider. Afterwards, the easy rotations, derotations with just a couple of aligners. I think again, and I sorry that I'm repeating this so frequently, I think this is a super smart combination. Another patient, ankylosed canine. We all know these cases. They are horrible for us and for the patient. So she was treated in a private orthodontic office nearby Düsseldorf. Canine was ankylosed, and this is how this patient has shown up in my office at the university. Yeah? Super unhappy. She didn't want to smile anymore. So what did I do? First, I took the canine out of the appliance and leveled the rest of the teeth. And now she was much happier than before. Okay, so far no rocket science, but after leveling and correction of this canting, we have to do something with the canine. Yeah, maybe you heard about our PDL distraction. We are loosening the tooth, and then we are pulling this out of the socket in 1 to 4 weeks, depends on how much we have to pull it, how big the distance is. But in this situation, we made a cone beam CT and we saw there's a big defect of this canine, and probably this was the reason for the ankylosis. So it doesn't make sense to align this canine. So treatment goal was to extract the canine plus close the spaces. So again, remove the brackets because I don't need them anymore. These are the mini screws. Nowadays power median, like I recommend. Took out the canine, and now we have to be fast because we want to be smart. We want to use this wrap phenomenon. What does it mean? We want to close the space as soon as possible because now space closure immediately after extraction is much quicker. This is a mesial slider in place. She was a nice patient, so I spent this temporary pontic. So you can add this pontic, of course, to your mesial slider to make the appliance a little bit more aesthetic. Okay, so this is a pontic. This is a additional wire. Of course, you have to cut this area from time to time as soon as spaces are closed mesially. So treatment goes on. Now I have cut this additional wire with the pontic, and this is round about after 10 months of treatment. Again, treatment space closure takes 0.6 millimeters per month. Okay, let's go back. You see the space closure, and the patients love it. It's not visible. Yeah, it's a bodily space closure. And now it's an easy case to finish with aligners after space closure. So minor things just with aligners afterwards. Some derotations, occlusal settlings, etc. But you see we have mesialized around 5-6 millimeters in the first quadrant. This is the situation after mesialization at the end of the treatment. Another patient where we have mesialized using the mesial slider and aligned simultaneously. So one phase treatment. Yeah? Insert the mesial slider passively, did a scan, and then simultaneously did some alignment. And of course, this is the fastest treatment option. After 10 months, spaces are closed borderly and the front teeth are aligned. This will be published in the upcoming JCO issue as well. Patient at the end of the treatment. Okay, so I have a couple of minutes left now. I'd like to give you a short outlook to my next webinar where I will speak about expansion with mini screws and alignment, molar intrusion, etc., but also about these new digital techniques using insertion guides and 3D printing. This was one of the first papers where we have published this. My good friend Simon Graf is one of the inventors of this 3D printing. I will speak about if you use these scan bodies. I will speak about design of these mechanics. And nowadays we are using insertion guides. Why? We can insert the mini screws and the appliance in just one appointment. And this makes fun from my point of view. Yeah. If you don't want to insert the mini screws by yourself, you can give the insertion guide and give it to the oral surgeon, and he inserts the mini implants in the morning. The patient is coming to your office in the afternoon, and you are inserting the beta slider or mesial slider. So it makes the use of these sliders much more professional. Yeah? You have a optimal planning of the insertion site, and again, you don't have to take an impression after insertion of the mini screws. You can use and insert the slider immediately. This was one of the first patients where I used this guide. So it's super easy. Everybody can do it. And you saw I'm counting from 10 to 0. Then the patient knows it's done in a couple of seconds. Okay, so you can do both in one appointment, mini screws and afterwards the bene slider. Yeah? And here you see what happens in 10 months. Molars are distalized. Bicuspids and canines are following. Yeah? Simultaneously. So it's a very easy case now for short finishing with brackets or aligners. Just a very short period. Nowadays, we can use these distalizers as well. So the bene slider is a sliding mechanic. You can use this activation screw, integrate this. The patient is activating this once a week. So this is a more compact appliance. But again, same story. The bicuspids and even canines are following. And now you can finish the case with brackets in a short period or with just a couple of aligners. So nowadays we are combining these insertion guides and the sliders to a full CAD/CAM service. And we started a service, a spin-off from the university in Düsseldorf. It's called TEDman.de, and I strongly recommend to check this out, this website. You can use this service worldwide. Just upload an STL file of your upper jaw with the palette, of course. We need the palette. And then you can order the insertion guide and a slider. You can order this hybrid Hyrax, medial slider, Bene slider, whatever. So again, please check it out. I think this is the future. Yeah, it's like ordering aligners. You can approve the design, and after your approval of the design, it will be manufactured. So again, today I talked about distalization and space closure. In my next webinar, I will speak about other combinations with aligners, primarily expansion, because it is an issue with just aligners. This is our university website. So if you take a picture of this QR code, you will find our university website with many free papers to download. Again, after the Corona crisis, I'm happy to welcome you in Düsseldorf. Every year we have a meeting. We had to postpone it to this year, June, and I'm praying, I'm hoping that we can do it in June, because we have some super speakers like Björn Ludwig, Marco Rosa. Kenji Ojima is one of the worldwide heroes if it comes to aligner techniques. Jörg Schwarze as well, and many others, Gina, Susanne, Patricia. Professor Stroop is prosthodontist. He will speak about dental implants in the aesthetic zone, and Prof. Drescher, he will speak about the CAD-CAM techniques. So it will be a super interesting meeting. So I'm happy to welcome you. And one of the main topics is aligners in combination with TADs. And I'm happy to see what colleagues in private office are doing, how they are combining the sliders and aligners, because I think this is the future for our orthodontic profession. This is a short video about this meeting. I'm happy to show you. So I just saw there are some questions. Question: how about designing this undercut? Yeah. So it's very easy. You don't have to do it for every aligner. You just do it once, scan for the aligners, and then every aligner is, of course, has the same undercut or attachment. Okay, so you don't have to repeat it. Sometimes this coupling may break. There's a small trick. I'm for rebonding. I am putting some resin on this bonded tube, and then I am putting the aligner in the mouth, and then you are doing the light curing. Okay, so this is only if you have a failure of this coupling. Another question: how is this tripod made? There is a special bender plate for this tripod, so you don't have to do soldering or welding. Just have a look for this bender plate with 3 wires in place. So these are the questions that were asked in the round. Okay, so you see it right here. Yeah, bond the slider, then take an impression or do a scan for aligners, and then the aligner company knows how to design exactly this big attachment. It's like a big tooth. Okay, so if some aligner company doesn't know how to manage this, just tell them it's a big tooth or it's a special attachment. That's it. Yeah. Okay, again, after distalization, use your steel ligature to modify your active banner slider into a passive molar anchorage device. And again, this is what I wanted to show you today, and I think you can be very successful with this combination for distalization more than 2 millimeter, space closure more than 2 millimeter. I strongly recommend to do this combination. So I've shown you one or two phase protocol, and this is true for distalization and mesialization. Two phase seems a little bit easier. So if you want to start tomorrow or next week, maybe it's better to start with this two phase. So first close space, distalize, then take an impression. And one phase is, from my point of view, is not a big issue because you have to synchronize. Just think about how to synchronize. Okay, and I'm repeating myself, don't rotate the molars if they are connected to the bene slider. Don't tip the molars if you're connected to the bene slider. Just a bodily movement. Speed is 0.6. Okay, this is all you have to know for synchronization. Communication with parents, if you want to start tomorrow, next week, avoid these words implant or bone screw because maybe the patient are afraid. Yeah, I'm using TAT, titanium pin, because we think these mechanics are fancy, they are cool, they are super smart. We have CAD/CAM designed. Yeah, but if you speak about bone screw or implant, patients may be afraid and think, oh, there's a nail or a screw in my head. Yeah, so show them pictures and don't use these words bone screw or implant. At the end, I'd like to thank you. You can contact me on Instagram, Benedict Wilmes. There is a website or a site about benefit applications. I strongly recommend this. I repost if there are smart ideas from colleagues using mini screws in the pallet. And the third site is Tedman.de. It's also available on Instagram. Okay, so if you have any questions, you can text me there. Again, this is our university website. And at the end, yeah, thank you, merci, muchas gracias. It was a great pleasure to be with you, and I'm happy to see you for my second aligner webinar. Bye bye.